Good afternoon, everyone, and welcome to our 84th session of MRF HIV STI ECHO. I am Dr. Gregory Boyce. I'm the disembodied head speaking to you today. We're not in the conference room, different layout, but we're still happy to see everybody today. Thanks for coming out at a day when a tropical storm is rampaging through the Caribbean. I hope we're all well and safe and dry where we are. And today we are joined by Dr. Chris Behrens, again, who's going to give us a presentation on something that we are recognizing, I think, more and more often, especially in among men who have sex with men. But we are also seeing it among some of our older clients, especially among older women who have been diagnosed recently, who have been diagnosed with anal cancer. But we're also starting to recognize those pre-malignant lesions. We're starting to pick them up. And I think now is a really, really good time to kind of, fill in that little knowledge gap that might be existing, how to identify a pre-malignant lesion, what to do about it when you find it. Does vaccination make a difference? Does treatment or intervention make a difference? There's so much learning going on right now. And I just want to turn over to Dr. Behrens. Thank you so much, and I give the floor over to you.
Okay, thanks very much. It's always an honor and a privilege to be invited to give these presentations. So I will go ahead and get going. Hopefully you're seeing this all properly. I want to acknowledge some colleagues of mine who are, have more expertise than I do in this. Dr. Stoughton and Dr. Stankiewicz-Karita and Dr. Polevsky are all, essentially specialists in anal dysplasia, and they graciously allowed me to borrow some slides that they had prepared. So some of what I prepare comes from them. I want to acknowledge our sponsors, as always, for making these series possible. I have no relevant financial disclosures. Our learning objectives are, hopefully by the end of this, you'll be able to discuss the pathophysiology of human papillomavirus infection, including its role in anal dysplasia, review the epidemiology of HPV infection and anal dysplasia and cancer, describe options for anal cancer prevention, screening, and treatment, and summarize results to date of a key study called the ANCHOR study, which is very relevant. So let's talk about human papillomavirus, or HPV, biology and natural history. There are actually over 200 types of human papillomavirus, of which 40 mucosal types infect the anogenital and upper respiratory tract. And of those, approximately 15 are considered to be high risk or oncogenic. Especially high risk are like numbers 16 and 18. They're all numbered. HPV 16, for example, causes about half of cervical cancers and the vast majority of HPV-associated anal and oropharyngeal cancers. HPV 18 causes about 20% of cervical cancers. And then there are some others. Genital warts are actually caused by a different flavors of HPV, generally 6 and 11. However, if we see genital warts, we know that HPV, is there, and it might not just be HPV 6 and 11. It might be 16, 18, or one of the others that is linked with cancer. So HPV is transmission actually by skin-to-skin contact. It's not by bodily fluids or blood. So this is, again, an example of, is HPV sexually transmitted? Well, I mean, it tends to be transmitted in the context of sexual acts and sexual, intimate contact, right? But it's not an STD in the sense of, it's not there in vaginal secretions or semen. But nevertheless, I think, whether or not you call it STD or not, it tends to occur in intimate, sexual settings. That's where it tends to get transmitted, because that's where you have very close contact from skin to skin. It can be transmitted in non-sexual ways, and there is, auto-inoculation. It can spread from one part of the body to another, from, say, touching that part and then touching another part of the body. This diagram tries to sort of show the pathophysiology of HPV infection. And so what you're seeing on the bottom there is a representation of the dermis, of the skin and all its layers. So we at the top is the superficial squamous epithelium layer, and way down below is the basement membrane and the basal layer of cells. And to really cause dysplasia, HPV needs to get down to and infect that basal layer. And it typically does so through breaks in the skin. But a particularly vulnerable point for HPV getting down to that basal layer is at the squamocolumnar junction of the cervix and of the anogenital region. It's an area where the type of cell transitions from columnar to squamous cells. And at that transition zone, it's kind of easier for HPV to get down there and cause and infect the basal layer of cells. And when it does so, you see the transformation of the cells that come from that basal layer, because these are the cells that are dividing and supplying the skin cells that go up top. They get distorted with large nuclei and even larger cytoplasm. They're called poikilocytes. And further, HPV is also shedded from these as well. And over time, if unchecked, if the HPV is not cleared or these lesions are not treated, you can see more and more dysplasia develop. And along the top, we see sort of the gradations of normal cervix. This example is for cervical dysplasia. Normal cervix followed by low-grade SIL, also known as grade 1 CIN. And then HSIL, high-grade squamous intraepithelial lesion, corresponding to grade 2 and 3 of cervical intraepithelial neoplasia, or CIN 2 and 3. And then ultimately, we can result in invasive cancer, where it actually breaks through the basement membrane, breaks through the dermis, and then can even spread hematogenously. So it's the exact same process really in anal dysplasia. On the left, we have normal basal layer and normal cells derived from that, proceeding upward and feeding the layers of skin on the epidermis layer. But then with infection, you get this gradual progression from L-cil to H-cil. This can also be categorized as anal intraepithelial neoplasia, or AIN grade 1. As it gets worse and worse, we get to AIN grade 2 and 3, moderate to severe dysplasia, and ultimately actual carcinoma, again, where it breaks through the dermis at the bottom. So, you can really think about what we know already about cervical cancer as being, very, very analogous to anal cancer and anal dysplasia, because pathophysiologically, it's almost, it appears to be essentially the exact same process. Now, their anal cancer arises from the most distal portion of the digestive tract. And again, almost all of it is associated with HPV infection, primarily HPV 16. But there are also these perianal cancers that occur distal to the squamocolumnar junction that are also HPV associated. And these perianal cancers are treated similarly to anal cancer and can also be detected on screening. So let's talk a little bit about epidemiology of HPV. Very high incidence of HPV infection following initiation of sexual activity. And the epi I'm going to be reviewing here is primarily from the United States. I do not know exactly what it is in Trinidad or the Caribbean region, but I suspect it's probably fairly similar. So at least in the United States, there's 14 million new HPV infections per year. and very high incidence after initiating sexual activity. You can think of it as the most prevalent, the most common STD or STI there is. Peak prevalence is within the first decade after sexual debut. That's when people tend to get it. Now, it's often cleared though, and so one can get infected with HPV, then clear it, then get infected again, then clear it again, or not clear it. It's that's why we don't necessarily jump on HPV infections or worry too much about getting them at a very young age, right? Because say teenagers, they typically clear it on their own. But we do see a cumulative incidence of ever increasing HPV infection among women. These data are actually from Washington State on the left, looking at how by the time women are in their 30s, over half of them have become infected with HPV, at least in Washington State. And on the right, this shows also the percentage of cleared infections in addition to persistent and progressive infection. So as I mentioned earlier, HPV infection is very common, but it's also common to clear it. And so in fact, often, within years, especially within the first year, most patients, at least most women, will clear cervical HPV infection, right? It's only a minority that will not clear it. However, that minority is very important because those are the ones that can progress to dysplasia and cancer. In the United States, the prevalence of genital HPV is fairly evenly distributed between men and women, slightly more HPV infection in men. But the presentation of HPV associated cancers, not surprisingly, is very different between men and women. In women, roughly half of those of the cancers associated with HPV are cervical cancer, with the rest being sort of an equal mix of vaginal, vulvar, anal, and oropharyngeal cancer. Yeah, it's worth knowing that HPV causes oropharyngeal cancer as well, and this is due to acquisition of HPV via oral sex. In males, the vast majority of HPV-associated cancers are oropharyngeal. So about 4 out of 5 cancers, with penile cancer making up less than 10%, anal cancer about 12%. And what we've been seeing over the years, at least in the United States, is a gratifying decrease in the rate of new cases of cervical cancer, as well as of death from cervical cancer. So decreasing incidence of cervical cancer in the United States, but on the other hand, increasing incidence of anal cancer and increasing rates of death from anal cancer in the United States. And this is what it shows, over time by gender. We're seeing this occurring. It's not just a problem among men. We are seeing steadily increasing rates of anal cancer among women as well. So really a lot of what we're going to review today applies not just to males, but also to women. They should be getting, screened for anal cancer also. We know there are certain risk factors for anal cancer. As I mentioned, infection with these oncogenic strains of human papillomavirus, especially 16 and 18. Other risk factors include a history of ever having a low CD4 count. This is typical of many opportunistic diseases and opportunistic cancers. Nadir CD4 count matters, even if someone is on treatment and now has a high CD4 count. If they ever had a very low CD4 count, that does increase their risk. Other risk factors include older age, smoking, a history of cervical or vulvar, HSIL or cancers, and a history of genital warts. Again, It's not that the warts transform into cancer, it's more that the warts are basically show that there has been infection with HPV, and so those other HPV, those oncogenic strains might also be present. And so this table just tries to give a sense of just what the relative impact of immunodeficiency is on rates of cancer. And I think the most relevant is this middle table here showing in people living with HIV, the rates of the relative risk of developing these cancers is significantly higher, and it's most dramatically higher for anal cancer, where you have nearly a 20-fold increase in the risk of anal cancer among people with HIV as compared with the general population. This is a very busy slide, and I'm not going to try and go through it in a whole lot of detail, but I wanted to include it as sort of a reference so you can look at it, because it's, I like the way it breaks down the risk among different groups for anal cancer, both by HIV positive versus negative, MSM versus non-MSM, and age, and by age groups as well. And so really what you see is the very highest risk of anal cancer occurs among HIV positive MSM who are, in the older ages, the 30 years and up, and ever increasing risk as that age progresses. So, of course, in our clinics, at least in the clinic I work in, and I suspect you're seeing this as well, we're seeing kind of an aging population because, frankly, we are succeeding with antiretroviral therapy. Our patients are living longer and longer. But with that, we need to keep in mind that risk of the cancer, especially anal cancer, is going steadily upward. And the ones at the highest risk are MSM who are HIV infected. But there is risk in other groups as well, including in HIV infected non-MSM males and females. The risk is not insignificant. So when you sort of put it all together and do some estimates, I think these are the kind of figures that are useful to keep in mind and are also helpful for counseling patients. It's estimated that among HIV-infected men who have sex with men, 5 out of 10, so half of asymptomatic men will have anal high-grade squamous intraepithelial lesions. So the high-grade are the ones that are closest to progressing to cancer. So that's kind of a scary high amount, 5 out of 10, half. It's estimated that 1 in 10 HIV positive MSM will get anal cancer over their lifetime. And so 10%, again, sort of a very alarmingly high number. Among HIV infected women, it's estimated that 2 out of 10 asymptomatic have anal high-grade squamous intraepithelial lesion. And it's just not known. We don't have the data to estimate how many HIV infected women will get anal cancer over the course of their lifetime. So to summarize a few facts about what we know about anal cancer. We know it's more frequent among HIV-infected men and women than the general population. That is a lot higher risk among HIV-infected MSM, and both HIV positive and negative. In fact, HIV-infected men who have sex with men are 80 to 130 times more likely to develop anal cancer than HIV uninfected men. I mean, that's just an astounding rate ratio. We know that anal cancer incidence is rising, both among men and women who are infected with HIV. But we also know that anal cancer is preceded by these precancerous dysplastic cells, high-grade squamous intraepithelial lesions, or HSIL, which offers an opportunity to try and detect by screening and intervene before it proceeds to cancer. So there are actually multiple opportunities for intervention along the timeline. There are, if we starting with folks who have never had HPV infection at all, and all the way up to and including the development of cancer itself. So we're going to walk through these steps, these areas where we could consider prevention interventions. So the first step is HPV vaccination, primary prevention. And primary, this HPV vaccine is, it's just terrific. And it really should be universally recommended and ideally universally taken up. Because the latest ones, the Gardasil 9-valent vaccines, very high level of protection against almost all of those, oncogenic strains. At least here in the United States, lots of behavioral interventions have been tried to prevent HPV. Delayed onset of intercourse, fewer sex partners, abstinence followed by lifelong mutual monogamy, correct and consistent use of condoms with all new sex partners. I mean, these are all terrific. They can work, but the problem is they tend not to be taken up as much as we might like them to be, right? So it's just far more realistic and frankly, far more effective to give these vaccines. And I think it's important how we frame these vaccines. Because this should not be framed as an STD vaccine when we're doing messaging to the public, to our patients, to other stakeholders within, say, the Ministry of Health. This is a cancer vaccine and an extremely effective cancer vaccine that we should be giving to all of our kids, before their sexual debut. But even after becoming sexually active, it's not too late. So these are some of the vaccines that are out there. The HPV vaccine started with Cervarix, a bivalent one that hit the most high-risk HPV strains, 16 and 18. And now the most recent one, the 9-valent, the 9-valent protects against 16 and 18. It protects against 5 other oncogenic strains shown there. And it also protects against a couple of strains that are notorious for causing genital warts. So, this is, I think, also hugely beneficial in its own right and can make it more appealing to people who might otherwise be vaccine hesitant, like, oh, hey, this not only will it protect you against cancer, it'll protect you from genital warts. And really, what we know is that these are extremely effective. The efficacy has been estimated at 97% against HPV-related lesions and cancer when administered to patients who are HPV naive. It's a high persistent response in nearly all vaccinated persons. The antibody titer is actually higher than that acquired by natural infection. We also know that this vaccine is completely safe and very immunogenic, even in patients with HIV. And interestingly, this study from Australia, I'm not going to go into the details, but it showed that when they started their vaccine program, they started with girls and women only, right? But even before they started vaccinating the men, they started to see a significant drop in genital warts among the men as well, right? So you get this knock-on herd immunity effect that is very real. This is not to argue that we only need to vaccinate, girls and women. It's just to say that there's an individual benefit to vaccinating these individuals, and there's a public health benefit in terms of promoting a herd immunity effect, which was actually documented nicely in Australia. Okay, so let's talk about secondary prevention. This really involves, first and foremost, screening and treating HSIL lesions, high-grade squamous intraepithelial lesions. So the rationale for this is that about 50% of cases of anal cancer or high-grade dysplasia present with localized disease, and there's a relatively high survival rate for that, but about 50% conversely a more advanced disease and much lower survival rate and quite a bit of morbidity associated with the treatment. You know, the treatment of anal cancer is not fun. The radiation therapy can cause a lot of problems with, you know, subsequent scarring, pain, incontinence, et cetera. So, you know, I think you can make a strong case for we want to intervene as soon as possible. We don't want to get all the way to actual anal cancer before we intervene. Now, as I've mentioned, there are a lot of similarities between cervical and anal cancer. It appears to be the, you know, pretty much the exact same pathophysiology here with HPV infection of a certain kind of cells. And it's even the same precursor lesion, what we call a high-grade squamous intraepithelial lesion or HSIL. And we have very widespread cervical cancer screening programs for detecting and treating cervical HSIL. But the question has been, can we actually, you know, extend the exact same screening and treatment approaches that we use in cervical cancer to screen and treat, you know, anal cancer or anal dysplasia? Well, we'll get to the results of what's called the anchor study, which gives us a nice answer to that question. But let's talk about ways we can screen for anal dysplasia. There's the anal pap smear. This is actually quite similar to a cervical pap smear. Essentially, but in a way, it's actually easier. You just insert a cotton swab, twirl it around, and I'll show some photos. And then you take it out, you shake it in the thin prep vial there, and whatever cells you've collected, you look at them under a microscope. The sensitivity, you know, has been kind of all over the place, and the specificity, depending on which study you look at. But we know that this can work. This is capable of identifying these lesions. Furthermore, you can add HPV DNA testing the same way we often add that for cervical cancer screening. And we can identify HPV oncogenic strains like 16 or 18 or other strains using HPV DNA testing. I think an important component of screening for anal dysplasia and cancer involves what's called the digital anal rectal exam. And we're going to talk about that as well. You know, there was a small study of 27 men who had sex with men who had early anal cancer. 93% of them had changes that were detectable on this digital anal rectal exam. And then I guess the highest quality gold standard is what's called high resolution anoscopy. And this essentially is colposcopy for the anus. And we'll show some of that as well. So let's go through these techniques in a little more detail. So the pap smear, anal pap smear, anal cytology, it's really quite simple. You simply insert a moistened swab, a Dracon swab ideally, until it gets past the internal sphincter and hits up against the distal wall of the rectum. So you go in a bit, but not too deep. And you simply twirl it around, sweep it in a circular fashion as you withdraw the swab. So you're getting samples from all aspects of the anal canal. And, you know, count to 10 as you withdraw while sweeping the sides. And then you simply shake it in the thin prep solution for 20 seconds and you're done. Like I said, it's like a cervical pap smear, only arguably easier. Now, the digital anal rectal exam, or DARE, it's really an extension of the digital rectal exam because we're including a palpation of the entire anal canal and looking at the perianal skin distal to the anal verge, okay? And I typically, include an anoscopy with a simple anoscope, if possible, so I can look, at the internal mucosa as well. But really, this is very easy to do. It's really just feeling and looking at the perianal region. And if there's anything that looks odd or feels odd, then you proceed to this high resolution anoscopy. So these are some guidelines that were proposed a few years ago in a journal as to the frequency and starting age at which we should be doing this. And I think it's worth noting that I think that HIV positive men who have sex with men, this should be done annually in those men who are aged 35 years or older. And certainly, if there's any history of anal dysplasia or cancer, at least annually and maybe even more often. HIV negative men who have sex with men, they should probably also have this done every 2 to 5 years in those over 50 years of age. And of course, those with symptoms suggesting anal cancer, well, they need an immediate evaluation, ideally with high resolution anoscopy, if anything unusual is detected. So I'm not going to go through all the details of this, but it's there for reference. I try to follow this. I'm trying to do this annually in my HIV infected MSM who are 35 years of age. I do an anal exam, the DARE exam, every year. So what is this high resolution anoscopy? Well, it's examining the anal canal and the perianal region using a colposcope. A colposcope, it's sort of like a giant microscope that gives you a much better view of that the region you're looking at. And as we do with colposcopy, we typically use acetic acid and iodine solutions to help us identify lesions. So this is the setup we have in the Madison Clinic, the HIV clinic where I work. The colposcope is shown there on the right. It's just a standard colposcope that's used for colposcopy. It's attached to a computer in order to very quickly and easily capture images to be looked at and stored for later analysis if necessary. And these are the equipment that is typically used. You see a simple anoscope there. You see several swabs, the thin prep solution, and the tips used for anal pap smear. So it starts with anal cytology that I showed you, and then anoscopy. An anoscope it's just a simple little plastic device that is inserted into the rectum with lubrication, and then slowly withdrawn, and with adequate lighting, you can really see the anal mucosa very well. And then with that anoscope in place, one can apply acetic acid to the anal mucosa, the squamocolumnar junction, and look for any lesions. So here's an image of somebody doing just that, shining the colposcope. And this is what they see, through the microscope, through the colposcope on the right, looking at the anal mucosa with some areas of interest sort of, highlighted there with a yellow line. So again, it takes training, to be certified and adequate at high resolution anoscopy, right? So I'm not, you're not going to come away being able to do high resolution anoscopy just from this talk and from looking at these images, but nonetheless, I thought I'd show you some of what we're looking at. So, these are actually normal images. use that you can see that transition zone from the anal to the rectal mucosa. That's that squamo-columnar junction that's sort of outlined more clearly with the yellow arrows. This, on the other hand, is showing a high-grade squamous intraepithelial lesion, or HSIL. It's the same. We're looking at the same mucosa in both the left and right images, but on the right, it's been treated with acetic acid, which really the acetic acid binds to proteins that are found in these poikilocytes. Bottom line is, acetic acid is very good at showing very clearly where there is a lesion of concern. Anal cancer, you often see bleeding. You see typically a fungating mass. It's actually fairly obvious often when it's actual cancer, and anal cancer is also often palpable as a firm mass on a digital rectal exam. Now, let's not forget about perianal cancer. This is why we do the digital anorectal exam. We're looking all around the anus as well for anything that looks or feels unusual. And so this is an example of perianal cancer, also HPV driven. All right, so there's, obviously, if we see lesions of concern, we're gonna, on this anoscopy, a biopsy of various regions is typically performed. And clinical assessment often correlates with the pathology diagnosis, but it's worth noting that, with random biopsies, often a normal appearing anal region will harbor HSIL lesions, just picked up by random biopsy. So how do we treat HSIL? Well, the treatments are pretty similar to those with which we may be familiar from treating cervical cancer. There are treatments that patients can apply, like imiquimod, 5-fluorouracil cream. And then there's office-based therapy, trichloroacetic acid, infrared coagulation, hyfricator, these, essentially kind of burn these lesions, surgical ablation, simply cutting them out. These, are worth doing, but they're often uncomfortable, difficult, and they can be, fairly expensive. So do they really work? I mean, if we see HSIL and we treat it, does it actually prevent progression to anal cancer? That is really the key question that we need to know the answer to, because if we're doing all these uncomfortable interventions and they don't do any good, well, why are we doing this at all? Well, we didn't know the answer to that question until relatively recently. The ANCHOR study is a very large multi-site study that's been ongoing for a few years. The clinic where I work is one of the participating sites in this study. And it's done in places all across the United States. And their Harborview Medical Center is the place where I work, up there in the top left corner in Seattle. And so what this study did was take people, HIV infected persons, at least 35 years of age, and if they had HSIL lesions, they were enrolled and randomized to either immediate treatment with the sort of treatment approaches I described of hyfrication, trichloroacetic acid, et cetera, or to what's called active monitoring, where they were closely followed. And if any signs of potential cancer actually developed on pathology, et cetera, they would be immediately treated, of course. But they weren't, those HSIL lesions were not treated immediately. So you had a nice randomized trial going on here among 35-year-old or older patients with HIV who had HSIL lesions in their anorectal region, okay? And there we go. Very complicated algorithm. I'm not going to go through it all, but you have the details there if you want to see it. This is basically what the details of, treatment might be versus active monitoring. It was cleared by the ethics board, et cetera. So in the active monitoring arm, there was high resolution anoscopy every 6 months, minimum annual biopsies, and biopsy at any visit of concern for cancer, option to be seen every 3 months if any concern for malignancy. And here are the results. They enrolled over 10,000 participants in the trial, about half and half men versus women in terms of the HSIL lesion distribution. And there were a few individuals, not many, who were diagnosed with actual anal cancer on screening. And so these were the results. These are the different treatment modalities that were applied to the various participants who were randomized to the treatment arm. Now, the analysis was actually stopped, or this part of the study was stopped early by the Data Safety and Monitoring Board after 32 cancers had developed in the overall trial. And so they performed an analysis at that point of what did we know based on based on 30 cases of anal cancer that developed in these patients. And what they found was that the treatment arm was associated with a 57% reduction in anal cancer, very highly statistically significant and clinically significant. So, the cancer incidence was less than half in the treatment arm as compared with the active monitoring arm. So very convincing data, I would say, that these treatments that were being used to treat HSIL were having a very real and meaningful effect in reducing the risk of progression to anal cancer. This is a Kaplan-Meier graph sort of showing, sort of visually what that difference looked like over time. Again, about over 50% reduction in risk over time. So in the interest of time, I'm just going to go through some of these. There were some adverse events. These treatments are not, completely benign, right? There's discomfort, et cetera. Especially most of the issues were around skin complications due to the treatments. But between the two arms, it was pretty balanced in terms of serious adverse events. And there were, so overall, skin irritation, local complications associated with treatment of the HL, sure, that happened more often in treatment arm, and we sort of expect that. But serious adverse events, not a major difference. So, as I mentioned, the Data Safety and Monitoring Board recommending stopping the study at this point because it was clear that this worked and wouldn't be ethical to continue randomizing people to active surveillance when they should be offered treatment at that point. From these study findings, we know that the rate of progression from anal HSIL to cancer is high, that treating anal HSIL is effective in reducing the incidence of anal cancer. And data should be included in an overall assessment for inclusion of screening and treating anal HSIL as a standard of care. So this is where guidelines and policy recommendations are going to be forthcoming soon. There are official guidelines in development from two separate groups, and hopefully with that we'll see more more insurance coverage of these procedures and treatments. So there is still a lot of work that remains to be done. Ideally, we would come with better ways to treat anal HSIL that it has less, less discomfort and less local complications. Ideally, we could better identify biomarkers for lesions that are more likely to progress versus regress, because some of these HSIL lesions actually do regress. They actually get better rather than worse. There's a clear need to scale up training programs for high-resolution anoscopy. And while this study was looking at, MSM, this was just looking at HIV infected individuals. We need to extrapolate this to other the risk and come up with very good screening algorithms. So I'm going to stop there and open it up to questions, discussions. I'm really curious to what, what the thoughts are about implementing this kind of thing in Trinidad, what your local resources are, and what your thoughts are.
Hi, thanks, Dr. Behrens. Excellent as usual. I know I have lots of questions I would like to ask, but I don't want to dominate the floor. So I'll open the floor to anyone who might have any questions, either unmute or type in the chat box. I'll give 5 seconds before I jump in.
Hello, Chris. So they recommend anal pap smears now. What's the thought on this?
I would recommend that there should be some kind of screening for anal dysplasia and anal cancer among high-risk groups, and that includes, the highest group clearly HIV-infected MSM. They should be getting some kind of screening annually. And let me just share the slides again, so I can go back to the key. There was a key summary slide, and I think the most important part is to do the DARE exam, the digital anal rectal exam. There we go. That's what I'm looking at. That really should be done at the intervals that are, I think, recommended in this guidance. It makes a lot of sense to me. What we don't have clear evidence about whether, doing anal PAPs meaningfully results in reduced development of anal cancer. The anchor study to date has only proven that if we treat HSIL, we reduce the risk of anal cancer. But we don't have that same kind of clear chain of evidence linking performing an anal pap smear as leading to, reduced rates of anal cancer. Now, we will hopefully get that answer from, the anchor study. And so there are two ways to look at that. You could say, well, we don't have the evidence that anal PAPs really make a difference. Or you could take the position that, say, Joel Palevsky, who's, sort of a leading expert and advocate in this area, who says, well, it's going to take like decades to prove that. And everything we know about anal dysplasia and anal cancer is that this is just like cervical cancer dysplasia. We know that pap smears make a huge difference for detecting and preventing cervical dysplasia and cancer. So we should just, even if we don't have solid evidence yet, we shouldn't wait for that. We should just go ahead and do anal pap smears. They're easy to do. We already have the, all the sort of technology and the infrastructure in place to process and look at these, since we already have labs that do that do cytology exam for cervical. And personally, I find that more persuasive. So I guess this is an area that is not entirely clear cut, but I would say if you can, I think it would make sense, at least to me, to include an anal pap smear in that annual digital anal rectal exam, or DARE exam.
Thanks, Dr. Behrens. Cyrus, your hand is raised. Go ahead.
Hi. So my question actually is to you, Dr. Boyce. If I remember correctly, some years back, MRF was supposedly starting an anal clinic. Where are we with that?
So we have the anoscopes. You have equipment to do just regular endoscopies, not high resolution endoscopies. One of the questions I was about to ask is what would be the startup cost of trying to introduce that, because as Dr. Behrens has said, and would require separate training to get someone competent in doing high resolution endoscopy competently. Because I think that this dovetails into the question I was going to ask. One of my concerns that there's a dichotomy in our MSM population is some of the younger MSMs who would have been vaccinated against HPV and who may benefit from the lowering of risk of acquisition of high-risk strains nearby. There is a group of older MSM who would not have been vaccinated at a point where they'd have peak vaccine efficacy, who may have already acquired high-risk strains, and who are in the most need of this kind of screening. I know this is a sort of a very operational type of question, but in terms of the investment required to set up such a service, what was the experience? And I know this may not be a question you can answer directly, but what is your sort of estimate as to what I would require if, let's say, we wanted to set up something, either MRF or lobby the government? What sort of numbers do you have to think about and staffing you have to think about?
Is that a question to me, Dr.
Yes,
Boyd?
sorry, yes, it is. Sorry.
Oh, okay. Just checking. Well, yeah, we have an expert in our clinic who's trained in it, and he trained someone else in it. And honestly, they said it took, about a year of doing these frequently to feel competent in it. I don't know if there's some sort of certification exam in it. Not that I'm aware of. But I think in terms of doing it, well, it really is just a colposcope. You want a colposcope through which you can take photos, and ideally, I guess that's not critically necessary, but it's nice to have those photos so that on future visits you can look back and see what they look like before. You have to have the, like Lugol's iodine and or the other solution, trichloroacetic acid, to paint on the anal mucosa to look for, to better highlight the lesions. And then, of course, if you're going to be doing this, you want to be able to treat these lesions. And there are lots of different options for treating. These are often the same kind of treatments that are used in treating cervical cancer. So I think the first place to look in terms of trying to recruit somebody to be an expert in this would be someone who already does colposcopy, because they're going to be very familiar, I think, with how the equipment works and how the treatments work and what to look for, right? So maybe what you could do is if you could find a gynecologist who already is quite familiar with doing colposcopies, or whoever is trained in doing colposcopy and is willing to come to the MRF on a periodic basis. I don't know if it'd be once a week or once a month or every 2 weeks, something, whatever the demand might be, to perform high resolution anoscopy on individuals who were referred for high resolution anoscopy based on an abnormal DARE exam or signs and symptoms of anal cancer, or an anal pap smear that was concerning, right? I would think that might be what you'd be looking at. It needs some room. Maybe you need I don't know that you need a huge room to do it. This is clearly an office procedure, but you would need some kind of setup, or maybe your patients have to go to where this person is with the colposcope, right? These aren't terribly portable instruments, I don't think. So I can't speak a whole lot to the, really detailed logistics, but I can, I showed you some photos of what our setup is. And hopefully gave you a bit of an overview of what the training was. And I also want to point out that, it's the HPV vaccine is, recommended to be given up to age 45 and MSM or, people at high risk of getting this. So even though they didn't get it, missed out as a child or teenager, it's the evidence is not quite as clear, but we think it's still worth giving the HPV vaccine in older individuals to prevent, acquiring new HPV infection.
Thank you, Dr. Behrens. That's very good, very clear. Again, any other comments or questions from anyone here?
And please do share these slides with whoever's interested. It's with all the photos, it's very large, but I don't know, you could convert it to PDF and it wouldn't be such a large file size. That's one idea.
Okay, sure, that's good. So I'm not
Yeah,
seeing-
the data are kind of sobering, it feels like this is something, we didn't really have our eye on, early on in the HIV and epidemic, and now we're starting to realize that this is actually a pretty significant issue.
Mhm. All right. So I think we're all inspired to do more, because we've sort of been seeing sporadic cases. I think the more we look, the more we find. I think the anchor study really just cemented that, yes, your suspicions were correct. This is a problem. I need to do something about it to stem morbidity and mortality in the future. So I hope we are able to formalize something. Because I remember something as simple as one of my clients having a papilloma what? Just about, let's say, 2 centimeters from the anal verge, internally. And we didn't have a good mechanism to get rid of it because we're a little too high up. So the surgeons wouldn't touch it. The gastroenterologist are saying it's not their problem. So I think we really need to formalize something and get something moving. So again, thank you for this. I think it was.
Is the HPV vaccine sort of universally available and implemented there in Trinidad? That's good. And how about is colposcopy widely available, or is that less easy to access?
Dr. Boyce, are you muted?
Was it rattling one and no one was hearing? I think I was rattling one and no one was hearing me, and because I don't have a camera, you weren't seeing my lips move. My apologies. So yeah. So yes, so